Hey guys, Don here. Welcome to Podiatry Practice Mastery. Kind of going over I call the $1 Million Minute. These are the things that help to get to the $1 Million mark and beyond. This is a recording of a day in the clinic on a Tuesday. So this is a full day. I'm in my Worcester office. So good, bad, and ugly. First patient was a no-show, and I had another patient, 10 o'clock, that was a no-show, but the other ones kind of showed up. So let's go over. First patient was a Lamisil follow-up, 31-year-old male. Got my fungal nail kit and the Lamisil. So one thing I've started to do, if you see my treatment sheet for Terbinafine, for Lamisil, it has like visit 1 nail sample. I'm not the way I'm kind of explaining it now is I just cross that off and I say, they could bill your insurance a couple $100 for this nail sample, so I'm not going to do that. I'll save you this money, save you the visit. We'll start the treatment. If we see clearing, that's great. If we're not seeing clearing, we'll either take a sample or switch it to another medication. So that's kind of how I'm doing it, and I have this all on my one sheet that I give them. And then I find like the key, and I was listening to a guy that I really like, Alex Hormozi. He talks a lot about marketing and business, and one of the reasons we don't have a system. If you don't have a system of how to explain things to patients, you're not going to do as much of the self-pay or a lot of the procedures. So you have to have a system. So I find this paper really gives me a system. It's all written down, kind of the process, the medication, the LFT, and then all of the treatment, other things like the biotin, the shoe zap, and the shoe spray. It's all in like a system. And so it's able to bring up the per visit value for my fungal nails higher than anyone else's. And so I think if you can do this, not just with your nail fungus, but if you can find a way to do this with, for example, your plantar fasciitis, your Achilles tendonitis, these other things. I used to use presentations. Now I like the paper a little bit better. Either one that I have in my pocket, my little prescription sheet that I use, or the printed one. And if you have this system, you have all of hey, this is how we do things here. So you can do this with like plantar fasciitis, as I've explained as well. And it just really delineates the process and makes it easier and clearer for patients of what you're going to do. So that's why all my patients get this fungal kit. My staff know what it is. Sometimes they say no to it, but for the most part, it just makes it a lot easier. So just a recommendation for you, if there's things that you have that you're not doing, that you believe in, it's probably because you're too busy and you don't have a system. There are certain things, though, you have that you don't believe in. So let me give you an example. I have Formula 7 here. I don't really believe it. That works that well, so I don't have it in a system. But I do have the other things in there, like, for example, the foam roller and the night splint and the anatomic shoes. And these are kind of all in the system of how I offer things to patients, and this is how you can get the per visit value up. Also orthotics and other types of things like that. It's part of the system of how we treat patients. Okay, enough on that blurb. Next patient she has a midfoot arthritis, and she had a cortisone injection to a couple of those joints. One thing we've learned with the new EMR is that with ModMed, when you do an injection, there's a kind of a screen that you can see body parts like tendons, ligaments, joints. So when you do a joint injection, you have to pick the joint picture, which you're selecting, but she did 2 joints. And the nice thing with ModMed anyway is it bills for both of those joints, and I did it with ultrasound guidance, and she felt better afterward, and she's going to come back as needed. Next was a number 6 out of 6. This was an anterior calcaneal beak fracture that was not healing for a few months in a cam boot, and we did 6 sessions of Shockwave. I'm going to see her back in 6 weeks to see how it's doing and get an x-ray at that time. Next was, this is a patient, I've never had anyone that's done this many, but she's on Swift number 7. And I also just throw on cantharidin. So one thing I've learned, if I do Swift and cantharidin, they get kind of mad if I bill insurance at the same time. So I either do the Swift and just throw on the cantharidin as a bonus type of thing. I don't bill them for that because then it just gets too prohibitively expensive. Or I'll just do the Swift without the cantharidin. But in her case, it's been so long. I can tell it's getting better because I find with Swift that the warts become less thick, less elevated, less bumpy and stuff like that. So I think she's almost there, and I'm going to do a 6-week follow-up. So usually for Swift, the first 4 I do weekly. The first 4 I do monthly. And then as I'm doing additional ones, I'm adding like time to it, like 6 weeks or a little bit longer, just to give the immune system time. Next was another patient with midfoot arthritis. They had orthotics, and she had orthotics, but she also got a cortisone injection for those, no follow-up. Next was a patient that got a diabetic foot exam, and he had some plantar fascial pain, so we got a plantar fascial injection. And he's going to be seen back every 3 months for routine care, so an office visit with those things. Next was a 51-year-old that had a porokeratoma, so I did that, lesion destruction for that. So in my new EMR, it's going to say boro, possible wart. And so wart would be the diagnosis because that's what's covered by insurance. Then she also has a lateral scar on a lateral ankle with a surgery by another doctor. And in that, I talked to her about doing some like treatments for the scar. Laser can sometimes help. So she was going to be thinking about that, but I did offer her the laser. The laser I just do, it's for scar. I do laser. It can sometimes heat it up and kind of help lay down the scar a little bit better, a little bit in a more organized fashion. Next was a ulcer kind of that came back. I debrided the ulcer. He's going to come back in 2 weeks. Next was a 58-year-old that had, once again, lesion destruction as well, kind of porokeratoma type of thing, or IPK. Next was a 6-year-old little boy. He had a kind of a unique thing. He had this like elevated second digit, like a curly toe bilaterally, and that's overlapping the bunion a little bit, or the hallux. He doesn't really have a bunion, but it overlapped the hallux. So I recommended him Xero shoes, Xero, and correct toes. And then he also had a retronychia on the left hallux. I don't know what caused this, but he had a retronychia with kind of swelling at the base, erythema. I don't think his shoes were too small. They may have, if anything, been too big, but we're just going to let it be to see if it gets better. I don't really have great solutions for this. I told him that the nail might get thickened, and then we might have to take off the nail. I don't know if anyone has any other great things, if anyone's tried like corticosteroid injections for these or anything else that's worked for these. But usually I just avulse the nail or just wait and deal with the nail changes that happen. Next patient was a number 4 out of 6 plantar fascia. I added to her, so she had done 3 sessions, and then she came back 6 weeks later. Now this is we're going to set number 4, 5, and 6 up, so I did number 4 today. I encourage her to do foam rolling in bed. Some of the older patients, they can't do foam rolling on the floor. They can't get down to the floor, so I have them do foam rolling in the bed. Next was a X-ray for a status post exostectomy on a medial fifth toe. This is like one of my favorite procedures to do. So she has this, and she's also going to be having a bunionectomy here in a couple months. For the bunion, she was scheduled 2 months before a wedding she needed to go to, so I advised her to wait till after the wedding. Now, this changing of surgeries can kind of be a pain for my surgery schedule. So recently we had an office meeting, and we're going to start like doing like an admin fee. I think it's like $200 or something like that, to change that, because it takes a lot of extra work. I don't know if anyone else does that, but if they have everything scheduled and then they want to change it for like a random thing, do you guys charge for that? I'd like to know if other people charge. We're going to try it. I just hope it doesn't come back to bite us in the butt, but that's something we're going to be doing here until it changes. If it changes, I'll let you know. Next was, this was my MVP, my most valuable patient. He's a 63-year-old guy. He has bilateral equinus, really big calves, plantar fasciitis bilaterally, but it hurts worse on the left. So the way I determined which one was worse is I did an ultrasound, and the left was really thicker, darker. And so the plan is he's going to treat the equinus on both sides with bilateral night splints, just so he doesn't have to wear them more than 3 hours. And he's going to do Shockwave on the left side, and I did start Shockwave that same day for him. So he did number 1 out of 6. He's going to get bilateral night splints, foam rolling, and I'm going to see him back in a week to do the next ones. So that was my MVP patient. And at the 3rd visit, I told him he's going to be scanned for orthotics. So I tell them like after a few weeks, then that's when we're going to scan for the orthotics. Next patient was a Shockwave 4 out of 6 for plantar fasciitis. Next patient was a 58-year-old female, follow-up on a fracture, got x-rays, and it did show some cortical irregularity, and so just confirmed that I didn't see last time because it was a newer one. Next patient was a 12-year-old boy that originally was seen for flat feet and apophysitis. His orthotics, he was really wearing them, and they're kind of worn out, so we got a second pair. Actually, with the company we use, they get a second pair for just the scanning fee, so it's $100. And so they did that one. They wanted another pair, so they paid full price, $600 for one, and then got that other one for $100, and then the next one we'll do at $100 as well. So we're just kind of going back and forth for that. This was a little 12-year-old boy, and the next patient was a 39-year-old did cantharidin for a wart. Next was another cantharidin for a wart, and there's another patient that had some neuropathy, and so we did gabapentin for this one, and he is kind of a challenging one because he had a kind of a blunt trauma that kind of caused like an RSD on the plantar sesamoid region, and we've done Shockwave, done Orthotics. Nothing's really helped him. He's been really shrugged off by a lot of other doctors, and he's like asking for a sesamoidectomy or a neurectomy. And I was like, I just have never done one of those for this condition, so I sent him to get a second opinion with one of my buddies here. So that was the day. Hope that was helpful for you. Just trying to share kind of what my thought process is and things. Hope this is beneficial for you guys. Just so you know, we're starting some touches on developing a mastermind, kind of a small group. We're going to limit it to, I think it's 5 or 6 people that we're going to be meeting to do like a hot seat kind of mastermind group. So if you guys are interested, shoot me an email, don@podiatrypracticemastery.com. And if there's other things that you do that I'm not like talking about, let me know and I'll share it with other people. Okay, thanks.